Thank you, Jessica.
Thanks everyone who has made it so far. I don't know if we can turn off, maybe Amanda, you can look into this. Actually, if you figure out how to do this, you have to tell me because I need to figure this out in my class, but turn off the what do we call it? The doorbell sound.
The dinging, yeah.
Yes, I still haven't figured out how to turn this off for Zoom in my class, which has the same sort of distracting problem. So maybe we can just take a quick look and see if that's possible. Thanks everyone for being here. We're really excited to have Eeshani Kandpal from the World Bank, who is an economist who's worked on a variety of really exciting research topics at the intersection of global health and economics, including research around cash transfers and especially pay for performance. So she's going to talk today about some really neat research on pay for performance contracts. And so we're going to do 45 minutes-ish presentation, and we'll leave the last 15 for some discussion. But I think we have mics muted. Please jump in with a question and I'll ask for you to be unmuted, or if you would rather put your question in the chat, I can sort of field it. And we're going to do clarification questions as we go along, and then we'll have some more open discussion at the end. So thank you, Eeshani, for being here, and we're excited to hear more about the research.
Thank you, Maggie, and thanks so much for the invitation. I'm super excited to present this, although as I've tweeted and as I've told Sebastian in person, presenting with co-authors in the audience is one of my less preferred experiences in life, and I have had quite a few opportunities to do this. That said, it is fun also to present with co-authors in the audience. So this is work with Sebastian Bauhoff, who is right there. In this paper, we're interested in understanding the specific mechanisms of pay for performance contracts that might be translating into any observed impacts that we might see of introducing such an incentive mechanism. So let me tell you a bit more. After 18 months, you would think I figured out how to move slides on Zoom, but I'm still having some issues. Anyway, so public sector bureaucracies in health and education, in government in general, are known to face principal agent problems. This has sort of been well documented in the econ literature. And to address this principal agent problem, the approach or an approach that's often been shown to or been hypothesized at the very least to increase worker productivity is paying for performance. This is again, not a new idea. Certainly, the notion that you can, when you have a principal agent problem, you can increase worker effort by linking remuneration or at least some component thereof to performance on pre-specified tasks has been around for several decades. In practice, the way that P4P contracts work is often by using checklists that tie prices for these pre-specified actions to the actions themselves, to documented performance, often cross-verified performance on those actions. But this method of implementing a P4P contract does a few things. First of all, by listing an item, by purchasing it, the principal is essentially conveying some information about the importance or the value that the principal places on that action. That they're measuring performance on it, they're willing to pay for it. That says something about the importance to the agent about that task. In addition, of course, the agent is expected to respond to that price. But this is tricky, and this is a question worth disentangling this information versus price component of the P4P contract, because we know that information-only interventions can also improve worker effort. So, to what extent is the effect of a P4P contract coming from the price versus how much of it is coming from the signal? And we know that P4P contracts can work in health in LMIC context. So, I'm sure all, if not most of you are familiar with the seminal study from Rwanda that was published in The Lancet in 2011 that showed that that tying performance to payments exactly in this way, using a checklist for a subset of all actions provided by health workers, in fact, increased service utilization significantly in Rwanda over business as usual. A more recent and sort of still ongoing systematic review and meta-analysis by my colleagues here at the World Bank, Sven Nielsen, Damien DeWolf, Adam Wagstaff, and Judd Friedman, shows that pay for performance, performance-based financing can actually increase the quality of care, which is sort of on the intensive margin, the effort that the health worker is providing in a particular patient-provider interaction. So in this paper, what we do is attempt to answer four primary questions. The first is, as I said, do the incentives matter above and beyond the signals that are being provided by that checklist that P4P contracts are typically using? Does it matter if the incentives are rewards or penalties? Does loss framing matter? And there's evidence, older evidence suggests that loss framing is hugely important. Newer work by John DeQuite and others suggests that often loss framing can be less important in practice. And so we want to understand why and to what extent. And then we're really interested in spillovers. So there's been sort of both in policy and in the economic literature and in the public health literature, concern that paying for a subset of tasks can lead to spillovers by crowding out effort on the unincentivized or the unpurchased tasks. And so we're interested in finding out whether the spillovers are positive or negative, and the extent to which spillovers can be actually priced in. So to give you a bit of a spoiler, what we find in our case is evidence of positive spillovers, and we generalize a model of worker motivation or effort that was first written down by Della Vigna and Pope in their seminal paper called What Motivates Effort. We generalize it to a multitasking agent, and we show that you should expect spillovers and the direction of the spillovers to vary in task complementarity. So when tasks are complementary in production, we show that you should expect positive spillovers, and the extent to which you have them, the size of the spillovers is going to vary in the degree of task complementarity and the degree to which doing one thing actually raises effort across the bar. So in our context, we are primarily looking at services of one type for maternity care. So by purchasing a subset of these services, you're actually increasing performance across the board in all services. On the other hand, often what P4P contracts will do is pay for performance on a subset of different types of tasks. So for example, you might be purchasing antenatal care, but the health worker in a primary health clinic provides both antenatal care and malaria care. And there you might want to be careful or might want to worry a little bit about negative spillovers as well. And then finally, we're interested in the degree to which effort increases in price. So, the World Bank has invested a lot of resources, both sort of financial, but also staff time in nailing the prices of individual indicators. And we're sort of interested in understanding, the extent to which effort linearly increases or does not increase in price, and what that tells us about potential slack in the PDF payment schedule and how much we should be worrying about nailing the price. What we do is we use two sources of data. The first is, and the primary source is a frame field experiment, which is also known as a lab in the field. And then we're going to supplement that using some data on real world patient provider interactions. The frame field experiment is for maternity care. It's for labor and delivery. The real world patient provider interactions are for antenatal care. So I want to be upfront and say that we're looking at sort of a hypothetical task in the frame field experiment. We're asking them to review hypothetical patient record reviews, patient records, and tell us what they would do. So that's what I mean when I talk about performance in this task. So there's no sort of costly effort beyond telling us what they would do. But we think it's difficult to sort of envision a setting where you would try to disentangle incentives and the role of incentives, of loss framing, and measure spillovers across all tasks that the health worker could be doing in sort of only a real world task. But we are able to talk about the persistence of these effects using real world patient provider interactions. To tell you a bit about our methods, a little bit more about the methods. So in the frame field experiment, we're asking health workers to review records that are called partographs, which I'm sure are familiar to a lot of you. They are a labor and management tool that is used widely in Nigeria. These health workers in particular, are supposed to be providing maternity care. They're familiar with partographs. They know how to read them and know what to do with the information that's provided by a partograph. Our sample is 1,363 primary health workers in 691 clinics in Nigeria. This was nested in the impact evaluation of a performance-based financing trial in these clinics. So these clinics were participating in a real-world PBF or P4P scheme. They're largely, in terms of cadres, these are community health workers and midwives. And the outcome that we use is to assess performance in our task is adherence to the WHO protocol for labor and delivery. And what's nice is this is sort of an international benchmark, and it is also the national benchmark. So we did make sure that what we're assessing performance on is actually fair, given because sometimes national standards can differ from international standards. In the real world task or the costly effort task, we observe actual patient provider interactions for antenatal care. These were conducted within the next 36 hours after our lab in the field or frame field experiment. The tasks were incentivized by the PBF pilot, but not by our experiment anymore. So we're now talking about persistence or spillovers from our lab in the field. For this, we have data on about 340, about a third or 346 randomly selected health workers from the 1,300 that are in the lab in the field experiment. And that's one in each clinic. So we have 346 health workers, 346 clinics. And here, again, we're looking for adherence to WHO protocol, but for antenatal care tasks. And again, these are actual patient-provider interactions. So to give you a quick preview of our results, so yes, we do find that incentives matter above and beyond the signals in both the frame field experiment and then looking at what we had incentivized versus what we had not incentivized in the frame field experiment. Also in terms of the effects that persist, we find that it's largely the incentivized actions where we see persistence effects. In the real world task, we're finding that the impacts are really only being driven by rewards, not by penalties. But in the lab in the field, it is impacts are driven by both. So it's sort of overall in the real world task, we can't rule out that the lack of impact of penalties is not a power issue. So it might be a slightly smaller effect, but perhaps due to power issues, we can't fully rule out that loss framing doesn't matter. In terms of spillovers, as I sort of already mentioned, we find positive spillovers. As I said, theoretically, this we show depends on the degree of task complementarity. But what we find is that the spillovers increase concavely in the earnings per unit of paid effort. So in terms of pricing in both directly incentivized effort and spillovers, we find that there is a significant amount of concavity, suggesting that the price is generally serving as a signal of salience, perhaps, of the task. And so in some ways, the price is amplifying the signal provided by the checklist. Let me tell you a bit more about the, actually, let me see if there are any clarification questions at this point. Not at that point for any. If not, oh.
I'll just ask a quick question, Eeshani, but you can come back. I don't know if you're going to show the partograph later or something, but how much is the partograph used in reality in this setting? Like, how familiar are the health workers with using that to manage labor and delivery?
Yeah, that's a great question. I will show you a partograph in a couple of slides. And it is something that they're supposed to use for every labor and delivery that they manage in these health facilities. And that is one of the reasons we felt comfortable using it. As you know, there aren't a whole lot of high quality RCTs on the impact of partographs on birth outcomes. There's some evidence, but not a ton. But the reason we decided to use partographs is because this is something that they use every day, or every time that they assist the delivery. Okay. If there are no other questions, I will move on ahead.
There's another question in the chat, sorry, from Austin. Are there other existing quality control or monitoring measures within this context?
So the big other intervention that this is cross-randomized with is the PBF trial that I mentioned. This is, and that it also says on this slide. There was a 4.5 million household PBF trial that I led the impact evaluation of, and that we embedded this in. This is cross-randomized with that, and we do investigate it. I can't quite remember if I will have enough time to get to those results, but we do, look at whether our results are being confounded by that, and we don't find any evidence that they are. Okay, so if there are no other questions, I'll continue. So, just a couple of things to note about the context. First is these are primary health clinics and primary health workers in Nigeria, where maternal mortality is extremely high. Nigeria is, if memory serves, the 6th from the bottom on the list of contributors, biggest contributors to maternal mortality, and bottom, I mean, really is one of the largest. It's the 6th largest contributor. Maternal mortality in Nigeria is 8 times higher than it is in India, for example. And the vast majority of births in Nigeria occur in the public sector, births that are attended. As I have said a couple of times, the study was conducted in the context of a larger ongoing PBF intervention. The PBF intervention was in these 3 states here, and then there were matched control states that were sort of next to them. So we have a sample of 6 states. The impact evaluation paper was recently accepted at BMC Medicine. So in it, we examined the impact of PBF versus budget equalization effectively. So conditional grants, conditional on performance relative to unconditional just budget equalization. And we actually find that the budget equalization paired with autonomy and supervision reform works really well in this context as well. Okay, so for our experiment, we had 3 study arms. As I mentioned, this is an RCT, so we randomized health workers into information only, where we just gave them a checklist, and I'll tell you more about that in a second, performance-based rewards or performance-based penalties. In each of the arms, they did actually earn something. So in the information arm, to sort of account for an endowment effect of sorts, there was a base pay or just a token of participation. This is 1,750 naira, translates to about just under $6 US at the time. In the reward arm, we started with a lower base pay of about 1,000, and then that was sort of the minimum they could get if they did nothing correctly beyond that, but the maximum they could get was 2,500 naira. In the penalty arm, we flipped it, but the contracts are, they're isomorphic as you would want them to be to understand the impact of loss framing. But they start out with 2,500 naira, and they can lose up to 1,250 of those. In expectation, we expected sort of the payouts in the 2 incentive arms to be similar, to be comparable, and that is in fact what we find. Payout in the 2 incentive arms does end up being about 7% higher than in the information arm, and that is in fact the effect of the incentives spurring on better performance. So we gave them at the outset in all 3 arms, all 1,363 health workers, we gave them this checklist that contained 7 out of the 15 possible common clinical actions that they could do for labor and delivery. In the information arm, this column here was obviously blank. In the reward arm, it said reward, and in the penalty arm, it says penalty. But as I said, these were isomorphic contracts, so the prices associated with the actions were always the same. We randomly, of the 7 that we put on the checklist, we randomly selected 5 to be incentivized. But we can assess performance not only on all 7 here, but we assess performance on all 15 of the possible actions. And that's how we can assess spillovers. So here's a paragraph. We had them read 5 of these. So a paragraph tells you, something about the stage of labor, how it's progressing. And there are these action lines where, once a woman gets to a point on the action line, you're supposed to do something. And so one of the things was sort of telling us what they were supposed to do based on the information that the paragraph presented about the woman's case. We designed these based on WHO examples. We had 2 medical professionals who reviewed them, which we contracted through Upwork. We set up 2 different types of, Sebastian, you just rolled your eyes. Do we not use Upwork? I think we used Upwork. Yeah, we used Upwork. That's what I thought. Okay, it's been a few years since we set this up. There were 2 simple cases in which we suggested the action and just required a yes or no response, and 3 complex cases in which we said, this is your patient, tell us what you would do. And so the goal here was to understand how high-powered or direct incentives need to be effective. Because we can measure, measure adherence to protocol in all 15 relevant actions, we can assess performance on actions that are not listed at all and not incentivized, actions that are the 2 that were listed but not incentivized, as well as actions that are directly incentivized, that are listed and paid. Here's what a simple case looks like. This is a screen grab from the CAPI, the interview template on the tablet. And here's what a complex case looks like. And so here, they had to sort of tell us everything, and we would record what they would do, the responses they gave us. This is sort of the scoring scheme based on for the 2 complex cases, 3 complex cases based on the 2 health workers, the medical professionals that we contracted based on their feedback. And so we know whether something is indicated, so that's sort of clinically necessary, whether it's unnecessary in a couple of cases, whether it's sort of ambiguous, in which case, it's not harmful, but there was really no need to do it. We have a successful RCT, we have characteristic balance, and that's kind of all I want to say about this. As I said, we did cross-randomize with the arms of the bigger PDF pilot as well. Here is the first result. So looking at the direct effects of incentives and comparing rewards versus penalties, we find that both incentive arms outperform information in terms of impact on overall performance, but the 2 incentives arms are not significantly different from each other in the frame field experiment. This is sort of the regression version of that. We find that, so because the cases have different numbers of responses, you can weight responses across cases, you can weight cases equally, or you can weight responses equally, and no matter which one we do, the incentives arms are generally significantly improving performance relative to information alone. The impacts are in fact substantially larger for the simple cases, which is indicative that direct high-powered incentives are perhaps unsurprisingly more likely to elicit a response. But in general, even on the complex cases, both rewards and penalties do increase performance. So now we can look at performance on the directly incentivized tasks. And here there might be, as we sort of discussed, as I've talked about a bit, there might be just from the signaling itself, there might be an impact on performance. So we can look at performance on the paid actions, net of performance on the actions that were listed but not paid for. And here, again, we find significant and large impacts of the financial incentives. Now,
and sorry, Eeshani, just a clarification on the last. I think Jessica was asking on the last percent correct by arm and type of action. This is the directly. Which outcome is this? Which directly incentivized task?
So right. So these are the directly incentivized. These are the ones that this is performance on the task that we're actually paying for. So in the information arm, this is what they perform on the. So I guess one thing I should mention is that the same actions are always incentivized, and the same actions are always either unlisted or listed but not paid. And sort of, hindsight being 2020, would have been nice to vary across individuals, perhaps what we were incentivizing versus what we were listing or not listing, but we didn't do that. But what this lets us do is say that on the tasks that were paid, this is what performance would have been, or it was in the incentive arm, in the information arm, if they had not been paid. And this is what performance is in the two incentives arms on those same actions, right? So this gives you the sort of the single difference, if you will. But we think that just by putting actions on a checklist, you are also having an impact on performance. Then we want to think of sort of a double difference, right? So if we want to just look at the impact on paid actions, we're not netting out the importance of the signal. The way we do that is by subtracting information on the tasks that were listed but not paid. And so that's over here. These are the double differences. Okay.
Great.
Okay, now we don't have a pure control arm. And the reason for that is, where we just sort of gave them partographs and asked them to tell us what they would do, because partographs themselves do provide information, right? So we didn't think that we could get away from sort of the signal that is conveyed by a paragraph itself about tasks. What we can do, however, is look at performance on the actions that were listed or paid versus the ones that were unlisted in the information arm. And that tells us something about benchmark level of performance. Right? So we can, and we actually find that in the information arm, there isn't actually much of a difference between performance in those two bins. We can also sort of be interested in performance on the unlisted actions. Again, the unlisted actions in the rewards arm relative to performance on the same actions in the information arm tells us the extent of the spillover, and the same for a penalty. Now, we also know from sort of real world data from work by several people, including my former colleague Jishnu Das, that if you pay for unnecessary actions, sometimes health workers will do them. And so to sort of, as a check of our, the test of our experiment, the validity of our experimental task, we actually paid for some unnecessary actions. And we wanted to see if health workers would respond to those incentives. This is a test of attention as well, right? Whether they're paying enough attention to understand that this is a way in which they can get more money. On unlisted actions, we don't actually find much of an impact in any of the arms. However, on paid actions, where we're paying for unnecessary actions or even harmful, or even ambiguous actions that are not harmful, but are at least not required, we do find that paying for them, especially in the rewards arm, does in fact significantly increase performance. There is not much of a difference between the two incentive arms, however. Okay, so now moving on to the price response, which is how effort responds to the price. So, as I said, we have performance on the same set of actions, always being incentivized or not incentivized. So what we, and price, we sort of varied price so that it was higher with a more salient or more important task. So something up here, for example, something that's priced at 300 Naira is referring a woman when necessary, because these are primary health centers. So referring up the chain is quite important. But, so if we see a high level of performance on that task, we want to know that that's actually what we're picking up is the impact of the price and not just the salience of the task itself. So what we do there is control for or account for performance on that same action in the information arm, right? So that tells us what the level of performance is, perhaps just stemming from the salience of the task when there is no incentive. And then we can look at sort of performance on, these are the listed and not paid actions, and then performance on the paid actions. And as you can see, the gains from incentives relative to information alone is really coming from going from 0 to the two lowest, or even actually the lowest positive price. Beyond that, there isn't much of a price response, which suggests that what price might be doing here is amplifying the signal. So it's more of a token rather than something that health workers are responding to linearly. And we find a similarly concave relationship when we look at spillover. So this is performance on the unlisted actions, and how that responds to earnings, how that varies in earnings over the percent correct paid actions, right? So how much money you're earning for paid effort. Again, suggesting that, by and large, the spillovers we see, you'll capture them just by paying some relatively small price per effort. Now, moving on to the real world task, we can look at tasks that are directly related to our frame field experiment. And so we have 3 specific tasks here. The first is taking the blood pressure of the woman, which was a listed but unpaid task. And then we have 2 that were directly incentivized in our field experiment, in our frame field experiment. And this is listening to the fetal heartbeat and palpating the uterus of the pregnant woman. Pulling both incentive arms, it does look like incentives improve performance on the tasks, the effect of the incentives persists even on these related tasks that are conducted, again, just to remind you, up to 36 hours after. But that effect is largely driven by the rewards, not so much the penalties. So in terms of persistence of effect, it does seem like it's possible that loss framing is almost harmful in terms of persistence. But again, it's not exactly clear if this is a power issue or not. But certainly the magnitudes would suggest that they are considerably smaller than the magnitudes seen for rewards. So, you might worry that given that this is a hypothetical task, so we're just taking up noise, and this is something we spend a fair bit of time worrying about in the paper and addressing in the paper. Since I've shown you, we can replicate real world overuse. So when we pay for unnecessary tasks or even harmful tasks, workers do perform them to a certain degree. But at the same time, they're also performing unnecessary tasks sometimes when they're not necessary, or when they're not paid for. The reverse of that is also true, which is that when tasks are required but not incentivized, workers are still telling us that they would perform these tasks when they are clinically necessary. We can also look at sort of response patterns to see if workers are just giving us the payment maximizing, effort minimizing response patterns, and that's not what we find. The largest impact of the incentives is sort of in the middle of the performance distribution, but in fact, if you look at the PDFs, they are for the two incentives arms shifted over, suggesting that it's shifted over to the right, suggesting that it's not just the tail. So it's not just that, there were people who were just not paying attention at all in the information arm, and the incentives are just getting them to pay a little bit of information. We can also rule out some confounders. You might say this is all we're picking up is knowledge and nothing about effort. So we can run placebo regressions, and the regression loads the impact on the incentive arms and not on the knowledge score, because we do have independent assessments of health worker knowledge. There's this paper by Claire Lever, Owen Osier, Peter Thorniels, and Andrew Zeitlin on pay for performance in education in Rwanda, and they show that prior experience of pay for performance can cause workers to exert greater effort. So here, it's potentially problematic that some of the workers were, even though it's cross-randomized, some of the workers were in fact in a pay for performance facility, while others were in a business as usual, while yet others were in this enhanced financing or unconditional financing arm. So we can again run placebo regressions, and again the regression loads the results on the incentive arms in our frame field experiment and not in the larger trial. Time spent on task is often used as a proxy for effort. And we do find that this is in the frame field experiment, but we also have the same finding if we look at the real world task. Time spent on task is in fact higher in the two incentive arms. This is the interaction with the PDF trial, which I've already mentioned. And so in summary, we show that incentives matter. We find that incentives matter over and above signals, and that there is limited impact of information alone. We find similar magnitude effects on the hypothetical task and the real world task, which we use to tell us two things. One is something about the validity of our task, and the second of our experimental task, and the second is about the persistence of effects. In general, we find similar effects of rewards and penalties, although in terms of persistence, it might be that rewards are more effective than penalties. We find positive spillovers from incentives, which we take to be stemming from the fact that these tasks are complementary in production. But we find that these spillovers increase concavely in the earnings per paid effort, per unit of paid effort. And then finally, we see that a small incentive captures most of the gains from incentives, right? The two smallest prices capture most of these gains. And this is again true for direct effects and spillovers. So this suggests that prices might be acting essentially as a nudge, and this is consistent, for example, with the payment for ecosystems literature. It is consistent with the cash transfers literature, which shows that there is a fair amount of inframarginality. What this means is that there may well be a fair amount of slack in the payment schedules of P4P contracts, and so all of this time we spend, so for example, in the real world PBF trial that this was nested in. Institutional deliveries were paid at $12 per delivery, whereas an antenatal care visit was paid at $1.20 per visit. And a considerable amount of time, sort of World Bank project manager time went into figuring out those prices. And our results suggest that that might not be necessarily something that we worry about as much, and that prices are really just amplifying the signal provided by the checklist itself. And then finally, I just want to close with a couple of thoughts on what this means and whether paying for performance is worth the additional outlay. So we find that overall incentives in the frame field experiment, but also in the real effort task, lead to about an 8% increase in performance. This is coming from a 20% increase in directly incentivized actions. And this leads to an increase in outlay in our task or in our experiment of about 5 to 7%. Now, one thing I do want to note is that we're abstracting away from the administrative costs of paper performance programs, and this can be substantial. So in the cost effectiveness analysis for the PDF trial, the big PDF trial, we estimated that about 23% of project costs went to admin costs incurred by the PDF arm. So this is going for things like verification. This is going for things like, figuring out the price, how to price different aspects. That is really expensive, and we are not including that in our estimation here. But just taking this 5% as a sort of a thought experiment, we can use estimates from Edward Okeke's paper that is this awesome title, When a Physician Falls from the Sky, I believe. In saying that, I almost keeled over here, which would have been quite something if I had succeeded in falling. But using his estimates, we can do this back of the envelope that suggests that this improvement of 8% overall, 20% indirectly incentivized tasks is comparable to the short-run effect that he estimates of adding a physician to a facility, and this is in primary health in Nigeria. But of course, improving the design of existing contracts might be more feasible than the extensive margin changes to staffing, particularly as health facilities are sort of stretched thin and governments are increasingly pressed for resources. And that's it. That's what I wanted to say.
Wonderful. Thank you so much. This is really interesting. I'll let people sort of gather their questions. I see an interesting one in the chat. How do you want to, about the nonlinear effects of incentive size? So the question is, could the nonlinear effect of incentive size be partly due to the social pressure from earning more than one's coworkers?
Yeah, I mean, that's a great idea. It definitely, we can't rule that out. We did not tell people what they were earning, what other people were earning. We did the experiment concurrently with all the health workers that were going to participate in the experiment at the same time to try and get away from some of that. But yeah, I mean, there might be, some internalized social pressure as well.
Yeah, so I'll take a quick question as other people, come up with theirs. I think the combination of the finding that the sort of information effects are not large, and that the big driver of the incentive seems to be any incentive at all. I thought the discussion you had around that is really interesting, and I wonder if part of this, and let me know what you think of this, but part of the sort of tension that health workers face is that they have a lot of guidelines and a lot of procedures that they should be doing for quality, and no guidance on prioritization or sort of, they essentially have a list of tasks that everything is absolutely urgent, and maybe they have sort of knowledge of what the right procedures are to take, but no sense of how do you prioritize if you're exhausted or burnt out, or you're tired at the end of your day, or you have more sort of paperwork or other responsibilities. And so any incentive sort of, more than acting like as a salience or a reminder, sort of helps you think about prioritization, or sort of moves you to one activity or another. I don't know if, I think you sort of spoke to this a little bit, but I was trying to think about what do we conclude about that for how to think about improving quality and changing health worker behavior. So I'm curious what you think about how this feeds into sort of generally what we know about the reasons that health workers do and don't follow guidelines.
Yeah, no, I think it's a great point. And I think I might have used salient sort of a little sloppily, because definitely to some extent what we have in mind is what you're calling prioritization, right? You're effectively saying that these are the things I want you to focus on, because this is what I'm paying you for. This is what I'm telling you I'm going to be measuring, right? So Ken Leonard has worked in Tanzania, right, where he shows that just repeated measurement can increase performance, right? And so that, you know, and he says that that's really the same thing, that you're signaling the principle of signaling the importance of the task by measuring it. And yeah, so it's you know, one of the things, for example, that people hypothesize about the effect of P4P, even on something like health worker knowledge, is that by measuring certain indicators, certain actions, you are conveying their importance. And so, you know, P4P should, in theory at least, also improve health worker knowledge. We don't actually see that by and large. We've been doing, Gil Shapira and I, with some others, have been doing like a 5-country assessment of the impacts of, first just benchmarking the constraints to quality of care using like a 3-gap framework, and then understanding the impacts of PBS on structural quality, on health worker knowledge, and on patient-provider interactions and real effort. And we don't see any impact on knowledge alone, suggesting that, you know, to the extent that it is just prioritization or salience, you know, that's not where we're seeing the big gains from PDF coming from. I don't know if that answers your question.
Yeah, it does. And Jessica's sort of question is similar, and I think you spoke to it now, but you know, what does your pattern of results say about how to back out the reasons for low quality care? And it sounds like, you know, some of the work is suggesting that it's not really about knowledge, either indirectly or directly. But Jessica, I don't know if you had any follow-ups on that.
No, that's right. It was just like a slightly broader version of what you were saying, Maggie, which is like, how do you take the, like, you know, one thing I was thinking when I was looking at your like nonlinear effects of payments, that any payment is effective, is you can probably take that and rule out the hypothesis that things are not being done because of like costly, like they're costly to some extent, or, you know, they're effortful. And, you know, just thinking about how like your whole pattern of results can tell us about the reasons for low quality care, I think is really interesting. I guess the one caveat is that, you know, labor and delivery is a little different because it's like a little bit like an emergency situation. I mean, it's not exactly an emergency situation, but it's not like routine care. And so a lot of these actions are being taken like within a cascade of actions. And so it may be that the action of fetal heart rate monitoring is like worthwhile to the health worker, or useful, conditional on like certain other things they've done before, or, you know, certain other things they could do after. You don't, there's nothing you really need to do to address that, but I think the sort of static nature of the measurement makes that really hard.
Right. No, I think that's a really good point. And I think, you know, this is where having a frame field experiment is nice, because it's sort of like, this is literally the first time you're interacting with this patient, right? Quote unquote patient is in the form of this partograph. And what would you do at this point? And you shouldn't, you know, and we sort of made it clear that they shouldn't assume anything about prior actions. That said, you know, translating, so one way, I think a fair way to read our results is that these are sort of an upper bound on what you might expect from performance pay, right? This is a very simple, high-powered, super direct incentive setup, right? In our now BMC Med forthcoming paper, you know, we're talking about smaller effects by and large, but also 23% of the health workers, they had never heard of the PDF trial, including ones who were like receiving payment from the PDF trial, right? So we set up these incredibly convoluted schemes, and we expect health workers to respond to them. But as it turns out, you know, a bunch of the time they don't even know about the scheme, forget about, you know, how they would respond to it. And so, you know, the fact that if anywhere you should expect to see performance pay leading to an impact, it should be in a setup like this, right? You don't need to go do the action. You just tell us what it is. And even there, we're seeing a 20% increase on directly incentivized actions. One other thing that it strikes me that I didn't point out that I should have is overall, the level of knowledge is quite poor. It is very consistent with other estimates of health worker knowledge, from other low and middle income country contexts. So we're talking about levels of knowledge that are in the high 40s to mid 50s. So there is room for improvement. I just, obviously P4P doesn't seem to be the way to improve knowledge, obviously. It's certainly not the most cost-effective way, but there is, overall, I think a fair way of reading this is saying that, P4P can only get you so far, but not beyond that. And then there is still a lot more scope.
Great. It looks like Kevin has a question. Go ahead, Kev.
Yeah, thanks, Eeshani. This was really fascinating work. I actually had a kind of a clarification question about the costly effort element of it. I wasn't sure whether, and you probably said this, I just missed it, was the sort of field experiment team sticking around and incentivizing those activities in the antenatal care, the costly effort afterwards, or was the experiment over and you just observed what people were doing?
Correct. So we just took the data from the PDF impact evaluation for our paper for that. So as it happened, when I set up the fieldwork protocol for this, I had them do the interview with the health workers, including the experiment first thing when they got to the facility, and then the direct clinical observations were done over the next 36 hours. These are actions that are paid for by the PDF trial, but that we no longer paid for in our experiment.
And so, I mean, I guess what I was, so you still have, if I remember it, you still have effects there. So like, what do you think is going on there? Are people, because presumably they understand that they're not getting, or at least the control arm of the PBF trial understands they're not getting paid for this, but they're still doing more. So is that like so you had originally interpreted the results saying actually information doesn't drive things, but is this a case of information driving things, or are they getting somehow confused, or is it kind of like a nudge like you were saying before, or how do you interpret that?
So we're interpreting it as sort of the persistence of the incentives we paid in our experimental task. We could look at that's a good idea. We could look at just what happens in the control arm. We're going to be underpowered, but at least it would be interesting to see what those estimates look like, because we only have about 100 workers for whom we'd have those estimates. But it's a great idea. We can look into that. I also see a question in the chat from Austin. Do you want me to take it?
Yeah, that's fine.
Sure.
I was just
yeah.
Go ahead, Austin.
You just mentioned the multiple different cadres of health workers, and I was just curious if you notice any differentiation in the actual responses to incentives based off of like training level, like sort of back to your point, like there is some sort of like knowledge threshold of like what you're even supposed to be doing in the first place. So if people are trained differently, are you more like, if you have better training, are you more likely to sort of adhere to the guidelines based off of the incentive than otherwise?
So let me answer this a couple of different ways. So no, we don't find, the results are sort of significant for all cadres that we look at, and when they're not significant for all. But let me answer it another way. So in this other work that I mentioned that I'm doing on sort of benchmarking the quality of care, we look at what explains idle capacity. We look at, variations in health worker knowledge and performance, and we actually don't find any variation by cadre, any significant variation, very limited variation. It sort of begs the question that health workers are doing a lot less than we would like them to. So in that benchmarking work, we find adherence for basic antenatal care, adherence to WHO protocol is on average, I think about in the high 60s, I think 60% of WHO protocol, and the countries in question are Central African Republic, Cameroon, Nigeria, DRC, the Republic of Congo. That's five. And we find that the only thing that sort of varies systematically is effort is So idle capacity explains about a third of underperformance, all underperformance in these 5 countries. And then things like cadre, training, experience, most characteristics of the patient don't matter. The one thing that matters sometimes is the patient's socioeconomic status. So they do tend to exert more effort when the patient is from a wealthier background or more educated. But that's not necessarily to say that's discrimination. I mean, that could also be the patient feels more comfortable asking for certain types of care. You might think that she's able to, pay for certain diagnostics or whatever. Just to be clear that we're not saying that it's discrimination.
Do you, in follow-up to that, do you find like differentiations based off of like the payment system in the countries themselves, like if it's publicly paid for versus paying out of pocket? Like,
no, we do look at user fees and how those correlate. We do find that the impact of PBF on idle capacity varies in whether or not there was a user fee regime or not. So in countries where there was no user fee, PDF does actually, P4P does actually reduce idle capacity. But in countries where there was a user fee, P4P actually can sometimes even increase idle capacity because the health workers might be earning less directly.
Great. There was one other comment in the chat here. If high-performing workers tend to be concentrated in some facilities, a question about sort of facility characteristics like work culture. I mean, I was sort of thinking about this myself. I was thinking about the, what do incentives do? I think the nice thing about the framed field experiment is you really, isolate some things about the natural environment that are tricky, and you kind of focus on how people respond to the incentive. But what isn't in that environment, I guess, is like the sort of supervision element of incentives of like someone knows, is paying enough attention to know that I'm like not regularly taking blood pressure, and so that's sort of not as present here, although maybe is in the PBF, and maybe the fact that you don't see big differences in those settings suggests that's not as important. But I was sort of thinking about elements of what incentives do that are not present in this sort of framed field experiment, and part of that is maybe like accountability, sort of visibility to supervisor, although I'm not sure how present that is in PBF programs either.
Yeah, so I think that's a good question. Often when the verification does happen, it's by a third party. It happens, sometime later. And then there are guidelines, sort of, how different can performance be on the day that the verification visit happened. In Nigeria, they found tons of fraud. And so, they had pretty strict guidelines for that. But that, of course, adds to the cost of the program on the other hand. So just to answer the question that was in the chat, we can include facility fixed effects, and our results are robust. So it's not sort of being driven by some facilities, but this bigger question of what the culture is in the facility and how that drives the impact of incentives is, I mean, it's a big one, not one that we can get into here.
Great. Well, we're at time. This is a wonderful presentation. Really great to hear about what you guys are working on. Super interesting and great discussion. So we want to thank you so much for joining us.
Thank you. I hope, Sebastian, you took good notes.
Yes, I did. And thanks so much, Eeshani, and everybody for the questions.
Thanks, everyone. Thanks, Maggie, for the invitation.